Okay, welcome back, everybody. I'm going to be chairing this panel as well. Same rules as last time. So we have about just smaller panel, so you have about 12 minutes. So you'll get a warning at 2, and then we'll stop at 12. Please keep a lookout for it. Kinjal there has the time. And everybody online is? Okay. So we'll just go in the order of the names on this booklet. Prerna from University of Edinburgh.
Good morning, everyone. I'm Prerna I'm a PhD candidate at University of Edinburgh. My larger PhD project looks at menstrual practices in informal settlements, particularly this field site of Kusumpur Pahari in Vasant Vihar, southwest of Delhi. This paper that I'm presenting on marginality and water and how it affects menstrual practices is one of the aspects of that research. And this is an ongoing fieldwork. It's not very well formulated, so I would really appreciate any questions and or feedback. And this research and this fieldwork particularly is also supported and funded by International Journal of Urban and Regional Research. So I will move a little quickly through introduction and literature and methodology because I want to focus more on the idea of what I'm seeing in the field. But to give a broad context to this research I try to employ ethnographies of informal settlements and the existing scholarship that we have on menstrual hygiene, menstrual practices, and cultures, to try to understand how women's everyday life and health towards menstruation works within a severe lack of water infrastructure in this field site. There is this idea that when we talk about informal settlements, a lot has been said, a lot has been written and researched about women, particularly in these informal settlements, especially through the work of Thorbecke when she talks about informal settlements in Bangkok and Sri Lanka, and in India, particularly Snellrod, when she talks about health in an ethnographic way, women's health in this informal settlement in Delhi. So it helps us to understand these unfamiliar conditions and these gendered conditions that women find themselves in these situations in informal settlements. And Meenakshi Thapan's work about women's bodies, embodied bodies as instruments of survival in these conditions also helps to contextualize how menstruation comes into play here. So my aim in this paper, in a broader PhD project that I'm doing, is to employ this ethnographic modes and aim to reflect through this cultural analysis of women's lived experiences in urban slums, exploring interaction between class locations, infrastructure, and cultural practices, and very particularly trying to examine menstruation as a dynamic individual experience within space of marginality and constant negotiations. When we look at menstruation and wash infrastructure, what happens about, in general about menstrual literature is that it is kind of two siloed area. One that looks at infrastructure, availability of products, water, toilets, privacy, and the other looks at this idea of culture, myths, and practices. So here I'm only talking about wash infrastructure for the purpose of this particular topic, but it also tries to what happens with menstrual practices is they become defined through this presence of infrastructure, social and interpersonal relationship, and thus cultural norms are very much negotiated with available infrastructure. So these are not two very separate ideas of how we look at menstruation. Infrastructure is not very separate from how cultural practices are negotiated. And menstruation is very categorically, especially in these current times, very categorically positioned within this developmental idea of how menstruation should be managed, recirculating discourses about urban places as quote-unquote modern. Thus, the definition of, even if you look at the definition of MHM and other menstrual-related interventions, they put an overt emphasis on hygiene, access to products, running water, clean toilets, and waste disposal systems. Within this framework, if we look at, just to describe the field site. So as you can see from this map, the Kusumpur Pahari is based in southwest of Delhi, and it finds itself within this dichotomy of one of the most affluent areas of Delhi, surrounded by these really upper middle class bungalows and malls. And to just give a brief idea about Kusumpur Pahari, the census of 2011 says it's around 17,000 residents, but it's a very outdated number now, and recent estimates come to around 30,000. Most of the residents are from neighboring areas, and the settlement is divided into 5 blocks, A, B, C, D, and E, but how they are talked about within residents is based on from where the people who live there from where they have migrated to. So a half of B block is known as Tamil block, D block is known as the Rajasthani block. So it's very much also based on these understandings of mobility, but at the same time, these are not very, very homogeneous spaces. I'll very quickly talk about methodology. If you have any questions about it, you can direct it to me later. But it's a very embedded ethnographic fieldwork, a lot of observation, informal conversations, informal group discussions, a lot of shadowing that I've been doing with the DSU by centers, the Anganwadi centers, and obviously interviews and semi-structured interviews. So this is the picture that you see with the truck is the tankers that come into Kusumpur Pahari. So Kusumpur Pahari grew very haphazardly after the 70s and 80s, and a lot of residents mark the time of Indira Gandhi's assassination, after which a lot of mobility increased in this particular space. And in these 50 odd years, this space has never seen running water. So how they get access to water is through these water tankers and the truck that you see there who go through these narrow lanes. And the first sight that you see when you enter Kusumpur Pahari is this line of blue cans of water in which the residents fill their water. So within this space, the code that I've also mentioned here is when I was talking to this Anganwadi worker, Sabu. She's a helper at the Anganwadi center, and I was talking to her, and she said that, you know, everything is fine. We have electricity. We have been living here for 30 years. I am fine, but the only problem is that there is no water. And as soon as a child is born, because we were talking about reproductive health, the first thing they look for is how to get water. Because a lot of labor is employed in trying to extract this water. These are just some of the pictures. The one you see this is the community toilet. The other one is how pipes are attached to these tankers to get piped water inside houses. These are some of the just to give an idea of how class is also very visible through different blocks of Kusumpur Pahari. These stairs are very important because women carry these tankers through these stairs, and it leads to an implication of a lot of complaints about back pain and health issues. So within this idea of this overwhelming side of lack of access of water, each family gets to fill water, and their different blocks have different mechanisms of collecting water. For example, in B block, the tanker comes every day, but each family gets to fill water only once in 15 days. But they have negotiated this community and this relationship amongst themselves where whoever's turn it is to fill the water fills for other 14 families also. But these negotiations, as had come in these talks, are very precarious. It's very common for fights to break out, and there's a lot of anxiety about getting sufficient water. So during my continued this time in the field, you see that obviously collecting water is very overwhelmingly gendered, and not just collecting water, but also negotiating that access of water. And this is where conversations around menstruation became very interesting. So a lot of women said that the first priority is drinking, cooking, and bathing. So the kind of products they use very much depend on the kind of, the amount of water they have with them that day. Building toilets is a number one priority because privacy is a number one priority. Particularly in menstruating days, they talked about how it's very difficult to use community toilets because they have to use toilets more. So a lot of people put the emphasis on building toilets, especially women, but they also stated that it's very difficult to maintain those toilets because maintaining requires water and cleanliness. So these ideas of how to maintain toilets becomes very difficult for them. When coming to menstruation, they also talked about, when we talk about products, for example, they talked about how cotton cloths, for example, a very favorable product to use during menstruation, is sometimes not very accessible because they do not have enough water, or they do not want to use the very limited water they have to wash these clothes and to dry them. So a lot of time they end up using disposable sanitary napkins. And one thing that has come constantly in the field is that there is not one product that they constantly use. These menstrual practices are very, very dynamic, and they change with availability and access to a lot of resources, and particularly water. So they also talk about the house of employers and how they can use the washrooms there. But very interestingly, in one focus group discussion, one woman said that, I don't want to tell my employer that I am menstruating, because we put in a lot of effort to shed this idea that we are unhygienic and dirty when we go into these spaces. And if I tell them that I'm menstruating, because it's so attached to the idea of pollution, it might make things worse for me. So while using toilets, as they say, as quote unquote good employers is helpful, that is also very much embedded within politics of pollution and purity that comes with menstruation. Another important thing about this idea of community and kinship. A lot of women say that they use discarded cloth materials because they are friends with one of the women who works as a tailor. So they use these discarded materials. They make tikonis, tikoni literally means cotton diapers for small kids, but they use that language to talk about how they build their own menstrual products through this access. And I'm just finishing up. And again, the notions of rest becomes very important, because collecting water is so important. Constant body aches because of collecting water and carrying these heavy cans leads to worsened cramps. They say that they do not have the privilege of resting during menstruation, because who is going to collect water? And there are negotiations within family when men do it too, but when you look at employment in Kusumpur Pahari, it's much more diverse for men and women. Most of the women are in domestic work, and they constantly reiterate that this profession allows them to take care of both the house, even the household, and the timings of how water is negotiated in the slum. So that's it. These are some of the other aspects that I have not talked about in this presentation about my PhD project, about mobility, how mobility changes practices, pollution, purity, work, employment. And I would just like to end with this anecdote about one Anganwadi worker who recognized me from 2 years ago when I was a part of an interventional activity in this space. And she said, you came for distribution of sanitary napkins. And after that, someone came to talk to us about how cotton clothes are good for environment and this whole idea of sustainability. And she's like, I know this. So there's this idea that when you do these interventions, when you talk about awareness building sessions that happen so much around menstruation, there is this pathologizing that they don't know, or that their knowledge is not quote unquote hygienic or good enough for the larger discourses around MHM. So thank you so much.
Thank you. We go to Maryam. Are you online? Yeah. Maryam from NUMS.
Yes, that's NUMS, National University of Medical Sciences.
Yes. Can you hear us clearly? Yeah, we can hear you too.
Yeah, I can hear you as well. Shall we start?
Yeah, you could start. You have 10 minutes. You have 12 minutes, sorry, and you will be told on chat when you finish your first 10 minutes. So just keep an eye on that.
Okay, I'm Maryam Riasat, and thank you so much for having me. My research is dystopia and healthy urbanization, and what I'm presenting is a part of it. That is illegal, uh, permanent temporaries, the illegal pathologies. So, dystopia and healthy urbanization is charted experiences of different communities, that is, underprivileged, diseased, unemployed, or deprived in different Kachi abadis of Islamabad. It is to explore the normative understanding of conventional approach of health, well-being, and human right. You will hear me talk about Kachi Abadi throughout the presentation. Kachi Abadi literally means the raw populations. Kachi Abadi is a population living in a self-built shelters without following the building regulations in a hazardous land or area without access to any basic human right, that is water, electricity, gas, sanitation, health, or even education. Kachibad is a place where residents live with the constant fear of being bulldozed or razed while doing the menial jobs of operating the city. The basic human rights are not granted, and the city is otherized and marginalized. All around the world, all around the globe, we call it squatter settlement or slums. But I believe through my fieldwork that these kind of general terms have different variability. So I'm going to use the word Kachi Abadi, the phrase we use here locally in Islamabad or the whole Pakistan. As well-being is very holistic, subjective, and multifaceted aspect of life, which is influenced by urbanization and urbanism. Modern urban planning oversimplified the complexities of human life by separating people as underprivileged as urban poor in slums and privileged in twin enclaves. The fortified enclaves propagated social alterations and alienation. It is easy to document the gap between rich and poor and how it is impacting the access to certain spaces, causing the inequality and inequity. Well-being of rich is very different from those living in the Kachiabadi Jade colonies of Islamabad. They are fighting just for an extra cough syrup in a free medical camp. We need to also understand that I've mentioned dystopia. Dystopia is not exactly an opposite of a utopia. A real opposite would mean that a completely unplanned society. But dystopia is a utopia that has gone wrong or serves only a fraction of society. A dystopia is much more common because it bears the aspect of lived experience that are subjective assessments through environment, lifestyle, status quo, health, and well-being. As David Harvey exclaimed, that planning comes from utopic thinking, and ideology in dystopia is just an unplanned side effect. Islamabad was one of the most ambitious projects of 20th century. A Greek urban planner, Doxiadis, designed the city that has left nothing to chance. The desire to create a utopia like Islamabad takes for granted the limitations and dangers it carries. The uncertainty of something intangible when transformed into something concrete generated a dystopia of urban infrastructure, people, hunger, disease, and infection. Prestige and humility, privileged and underprivileged, developed and Kachiabadi. Today, about 0.37 million people are living in Kachiabadi that are not included in the mainstream population. This is the statistics from UNICEF 2020. The post-colonial transition of economy exploded a wave of restructuring in modernity and capitalism. For the functionality of power in a hierarchy, the construction of Islamabad became essential to claim true independence. The research looks into the Abadi population and the Forted population to make an understanding of the normalcy of representation in colonial modernism. The research is a case study of Islamabad, which is looking into both extremes of the city, trying to find a place outside of these dichotomies to make a sense of poor elite and CDA. CDA is the Capital Development Authority. The urban ecology has reduced societies into class, status, and sectors of Islamabad, that is from A to I, where they are controlled and confined. And this study is very purposive in locating the subaltern realities and how they are patronized and settled and planned hierarchies of Islamabad. For the methodology, different tools were used for data collection, like participant observation and in-depth interviews that were not structured. Literature review was done, to understand the already established theories about urbanization, urbanism, class, and power. In-depth interviews with locals as well as academic experts were conducted to develop an understanding of different narratives, and focus group discussions were also conducted to know the already built normatives of privileged about the privileged and vice versa, which was analyzed through the literature. Urbanization and city development is endangered through the feudal development, said a feudal temperament. A philosopher, Dr. Abdul Manan, said that during a interview with me. He told me he stresses that material, concrete, and planning is just one aspect of city. It has to be seen through a holistic lens of sociology, politics, and environment. Feudality exists in modern terms in Islamabad, where class war is instilled and infused. The rapid urbanization, industrialization, and capitalist expansion of Pakistan reflects colonial modernity, which is very static, but also very relative. Cities, as Louis Mumford said, have packed people together in walls, defensive corridors. Modernity is also fortified. People are modern in force, as civilized, law-abiding, and legal. However, the population settled at the peripheries are not modern. Therefore, they are uncivilized, barbaric, illegals, and criminals. The evolution of slums is a direct consequence of master planning of Islamabad. During an interview with a worker of Awami Workers' Party, he said that the slum population or the Kachi Abadi population are the pillar of the society. These are the people with no legal status. They are in the lower echelon of labor employed in as construction workers, vegetable market workers, sanitary workers, transport, house help, security works, and other menial jobs. The planning authority labeled them as temporary requirement of the city. The populace is either contract-based or daily wagers who are not associated with the income centralization. Therefore, their social, political, and physical needs are fortified. The people of Abadi are pocketed in temporary settlements. In the late 1960s and early 1970s, the capital authority was more sensitive toward housing of lower income class, following the hierarchy of rich, middle class, and poor, sectors established on variability. However, the authorities, the CDA, forgot to add people who are not in either of these categories. The daily wagers and construction workers are poorer than the poor and eventually have no spaces in the capital ecology. Dr. Asim Sajjad exclaimed these populations as required people. We locally call them darkar. This statement gives us a dynamic understanding of how Abadi population is an essentiality in the city who manages the capital, but their relation with the city is very asymmetrically reciprocal. The asymmetrical relation of politics, economy, health, education, and overall well-being with Abadi population is also institutionalized. The informality of the population is developed through planning. Construction workers or daily wagers are contained in the ghettos to control. These ghettos are temporary as it is settled on allotted roads of parks, schools, and other any mega projects. When a new project starts, these settlements are displaced to another location. Therefore, Dr. Arslan Wahid, a anthropologist, called these settlements a condition of permanent temporaries. They are temporarily settled on a land of no value, and they are settled temporarily for a permanent tenure of their life. These permanent temporary settlements, small congested pockets, are built with inferior housing, which is a dire panopticon. The ghettos are segregated from the main city. A modern class concept of untouchable rights in Islamabad in context of class war. The Western concept of white supremacy is instilled in the army and business elites of capital, where the material has characterized people in different classes based on capital and social habitus. When segregation was planned, so was the labeling with strict surveillance. No modern, non-modern pocketed sectors were otherized and criminalized as barbaric, evictees, outseas, and we call them slum dwellers. The settlement in the early development stage was negotiated as the city needed construction workers, but when the construction was done, eviction started as settlements were displaced. For example, the case of PIMS. PIMS is Pakistan Institute of Medical Sciences. When it was established, conflicts arose and people died. At the first two camps were arranged by the authorities, but later, as the city was flourishing, it was suggested to the Abadi by the CDA to arrange their tents or camps near construction sites, which were demolished later by CDA themselves. As at that time, it was more of a reciprocal relation because CDA and the settlers, it was a reciprocal relation between CDA and the settlers. Then a political economic relation. The settlers were distributed into small pockets near F6 and F7 sectors under CDA patronization, as these plots were of no value at that time. There were no plans for the laborers in the master plans of Islamabad. So spaces were allotted to them as they were not needed but required at the same time. This generated a condition of permanent temporaries. The authority made the temporary housing and jobs a permanent feature of their life. Now, CDA has fully contained them to control them. They designed the illegality and depicted the picture of malevolence. The malevolence also comes with extra cost, that is the monthly bribes, locally called bhatta. The authorities give a deprecated the settlers, which was reciprocated with money, seemingly portraying you mind your own business and I mind my own. But the undertone is we give them money and we get harassed every day. The official entered our houses and we are dishonored. And what can we do? We have to live with this if we want to live here. This is quoted by one of a resident during a interview in Jade Colony. The monthly share of money does not provide security of tenure to the Abadi resident. That is, they do not have any legal status. On the other hand, CDA holds the legality and eviction power over the Abadi. The case, there are different cases where a colony was raised, a colony of 30,000 to 35,000 people was raised in 2015, even when the court issued a stay order. These residents lived there for over 20 years but have no legal status, as when the location was required for another mega project, the whole colony was demolished. The legal power was not with the state, but when they encouraged these settlements in name of malevolence and political interest, but kept on exploiting and blackmailing the Abadi population. The relationship of exploitation is a part of the policy, which is not documented but implemented by the CDA. The Abadi is yes.
If you could take the last 1 minute to wrap it up, please.
Yeah, sure. I'm so sorry. I didn't do the time.
That's okay.
The legality and illegality of sure. The legality and illegality of the capital are regularized as capital inception is anti-poor, which was discriminatory and capitalist. The value of people and human rights depends on the value of land. When capital is included, laborers, as Karl Marx said, can be replaced, and they're the hawks of human rights. Social stratification is the problem of have and have not, which raises new cultures in urbanization. Industrial urbanization is based on the capitalist mindset, which is also colonial. The construction cost is divided between government and private citizens. The land is a major detrimental force in the relationship between CDA and the Abadi and their legality. The cycle of settlement and displacement is a story of 6 decades. People are displaced, villages are razed, and nature will, which is a partner of well-being, is romanticized to obtain money by the state and institution. CDA support the institutional hawks of human rights and legal status. Settlers are displaced from one settlement to another with the encouragement of CDA and re-establish their houses from the basic particles. And the misery doesn't stop here. Another official will come and to get some, kharcha pani, the deeds in the tables from the people already living in the dumps.
Sorry, I'll have to really.
Yeah, sure. I'm done. Okay. I was going to say the last line. Okay. To prevailing poverty and growing illegalities are not the problem of people or the state, but the problem of mindset and conscience. And this mindset is the white elephant while we are running behind the small chickens. The mindset of colonial modernity has initiated the class war, instability, and power constraints. To undo these sustaining disparity of well-being and healthy urbanization, society has unified the fragmentations of and make sense of each fragmented identity. I'm so very sorry that it took some extra time. I'm done. Thank you so much.
Thank you. We'll now move to the next presentation. Anuj, are your co-presenters also here? Are your co-presenters also here? Okay, so we have Anuj Ghanekar and Mohit Sood and Khushbu Chauhan, who are going to present on primary healthcare centers in Surat, India.
So, good afternoon. My name is Anuj, and I'm going to present with my two colleagues online, Mohit and Khushbu. And first of all, thank you for this opportunity to present our work. And our research is titled as Unfolding Adolescents' Responsiveness for Urban Primary Health Centers, a case of Surat in India. And this is going to be the outline of our presentation. In this presentation, in interest of time, we have more focused on recommendations emerged for urban health policy and practice, rather than talking about more data or knowledge production approach. So, to set up the context, urban adolescents in 10 to 19 years age group represent the group experiencing age-based marginalization. 20% of population in urban India is adolescents. So on one side, adolescents are perceived as capable group, like their physical, cognitive, social development is in transition. They are enthusiastic, they are more quickly adapting to changing technology, changing world, and they are supposed to be tomorrow's citizens. And on the other side, they are vulnerable to health in different ways. So according to an estimate, 60% of premature deaths in adulthood have some root in adolescence. For example, problems like lifestyle diseases, malnourishment, respiratory infections, etc. Also within urban adolescents, there are overlapping marginalization with respect to gender identities, social identities, their schooling status, migration status of their families, whether they belong to early adolescenthood or later adolescenthood, socio-economic class. So for this thematic context, there are evolving policy windows. There had never been specific adolescent health policy in India, but the nascent programs were always evolving, and the recent national program, Rashtriya Kishore Swasthya Karyakram, has been the most comprehensive at policy level as far as all other programs. So this was the inquiry for this study, and this was done in geographical context of Surat city in Western India. It was done in urban primary health centers, which are one of the most important stakeholders for this program implementation, and Surat has been one of the first urban rollout for this RKSK program. Then what we actually did, so in fieldwork 2022, last year, we adopted this strategy of embedded case study approach, where our broader case was rollout of urban RKSK program, and nested within that, we purposely selected 2 urban health center cases and low-income neighborhoods in relation to those urban health centers. We applied multiple methods, predominantly qualitative, covering all different stakes and perspectives involved, like adolescents themselves, other neighborhood members, and mainly service providers, making it a holistic study. So numbers, I'll not go into details, and you can see on screen. And the analysis was iterative in thematic manner. Now, the findings that are emerging are arranged in 7C framework of RKSK, and the first of it is coverage. So many of these C's are overlapping actually. So the coverage means whether health centers adequately cover adolescents whom they actually aim. So many strengths we found in that. For example, health centers were allocated with defined catchment areas, The maps were updated. There was good micro planning as far as outreach services are concerned. But there were also gaps, like the distribution issues were there. There was so much focus on numbers and targets, completing the targets and data getting piled up at health centers, but it was not actually used for taking evidence-based actions for adolescents. Then health center was understaffed. The staff was not as per the norms and feeling overburdened. Practices like mapping vulnerability of adolescents were absolutely missing. For example, the coverage of migrant population, there were many issues. So there were well-designed tools available. For example, the one shown in the picture, it is not visible, but just as a representative case. So it is the annual family health survey conducted by health system. And it is really a good tool as far as design is concerned, but it is extremely underutilized in terms of data collection and analysis. So ultimately nothing happens with that data later. The second C I will talk about is convergence. What we found that within same neighborhood, multiple vertical programs were covered, all you can see on the right hand side of the slide, within health and outside health, targeting same group of adolescents, but all work in fragmented manner in silos or situational kind of partnerships. There was no common area of command. There was no joint capacity building, joint review, data integration was not there. For example, in this shown, the basic different programs related to health had different definitions of adolescent age group. So the data integration and everything was, long dream, but it was more problems at that level, what we observed. Now I'll invite Mohit to continue.
Thanks, Anuj sir, for giving this talk a great start and elucidating all the points very well so far. My name is Mohit. I am a public health professional. I would like to continue our presentation and discuss content. When we are talking about content, it is about what kind of different problems the adolescents face. We recommend a shift at three different levels. At the first level, we observe that the health system mostly focuses on curative services, and it needs to also improve its focus. That's why it needs to improve its focus on promotive and preventive services. At the second level, we observe that before Rashtriya Kishore Swasthya Karyakram, all the adolescent health policies were solely focusing on reproductive and child health. It is important that RKSK has highlighted the importance of urban specific issues like mental health, injuries and violence, substance abuse, non-communicable diseases, nutrition, but a shift is required to include adolescent express local needs, which are not captured by a top down or centralized health policy. I would like to highlight some examples. We actually have a lot of examples, but I would like to highlight some examples, two specific examples related to our study. In our study, majority of adolescents reported coming to the urban health centers with dermatological and gastrointestinal problems, which are not covered under Rashtriya Kishore Swasthya Karyakram. The urban health centers didn't have a specific reporting format for road traffic accidents or injuries. And we all know that road traffic accidents are a leading cause of mortality, especially for adolescents, and they also affect the urban adolescents a lot. Third shift is that the current lens to view the health system's problems is very linear, but there are many systemic concerns which are very much pronounced in case of urban areas like climate change, urbanization, and poverty, which need to be considered. I would like to highlight one example to express this. For example, during our study, we found out an adolescent girl who was facing waterborne diseases. She was residing in slums and she was facing waterborne diseases due to drainage problems. There was flash flooding in monsoon, which is a climate change problem, and she missed her school, which is an education problem. For adolescents, this states that health problems have different complexities. Talking about clinics, the urban health centers examined were doing fairly good across some broader indicators like infrastructure, equipment, cleanliness, confidentiality, and user satisfaction. These were the strengths of both of these urban health centers that were covered as a part of study. There was some room for improvement in areas of visibility, awareness, health promotion, demand generation, management of protocols, adolescent specific capacity building of staff. Because many of the health center staff didn't receive any formal training to handle adolescent specific problems. Referral and follow up, usage of technology, timings for adolescents, because they generally conflict. If you look at the operational timings of urban health centers, they conflict with the school timings of adolescents, which is a major barrier for access and motivation culture among staff. Only 10% of the adolescents in the case studies coverage or catchment area of the urban health centers were utilizing or availing the services, and all of them were from lower socioeconomic class. Out of these 10%, none of the adolescents were using them for promotive and preventive health services. All of them were using it only for curative services, which I also explained in content part. This patient flow diagram that you are able to see in the screen right now highlights the non-linear pathway for adolescents to seek care, which is very haphazard. And this can be better streamlined, right from the time of getting the case paper issued to going to the doctor, availing medicines and leaving the health facility. Talking about counseling, urban counseling needs are different. Issues like cyberbullying, social media insecurities in this world of social media, adolescents dropping out of school, substance misuse, junk food are very urban specific problems. RKSK has a provision for dedicated counselor, but in the urban health center, the HIV program counselor is responsible for counseling all the patients, which doesn't cover adolescent specific need. This is also due to the lack of training and focus. Counseling is also limited to physical health, with broader issues like mental health and social and cultural phenomena receiving little attention. Standardized tools like patient health questionnaire 9, which is a standardized tool for screening of depression, can be integrated to screen the adolescents for depression. We also need to strengthen the referral mechanisms and have standard operating procedures for counseling adolescents. The counseling should move beyond just information giving and follow diverse evidence-based psychosocial approaches. Thank you. I would like to highlight it. I would like to kind of give it over to Khushbu to take this forward. Thank you.
Hello, my name is Khushbu.
Khushbu, you can just explain communities section with interest of time.
Okay. I will continue with the next, which is communities. This is about to focus on the outreach services of the health center. Heterogeneity in the urban areas play important role here. First, RKSK policy has the two important platforms in its design: adolescent health celebration and the peer educators model. These are meant for the preventative and the promotive activities. But we found these platforms were extremely underutilized and difficult to involve the adolescent. Second, their retention as a peer educators was low due to their life condition. Adolescents were offered expecting money for their participation. Third, this program also had gendered barriers. At least girl had Anganwadi center as a dedicated space to go, but there was absolutely no plan to involve boys. Substance misuse among the boys, gender-based violence, these were the burning concern, and parents had fear to send their daughters alone for any such public activities. Fourth, on other side, adolescents had good knowledge. They knew many things, especially due to social media, but knowledge was not getting translated into the healthy action. Fifth, there were some innovation done by NGOs and the school, but again, no convergence with the health system. Sixth, community health worker like the ASA, Anganwadi worker were doing their best, but they were needed hand-holding and the supportive supervision in this challenging environment, which was totally missing. Over to you, Anuj sir.
Okay, thank you, Khushbu. So there are some other findings related to communication, but we will not go into detail because of time. And thank you.
Thank
We
you.
are happy to discuss anything in the feedback section or questions. Thank you.
Yeah, we have the last panelist, Arunima from WRI.
Okay, good afternoon, everyone. I'm Arunima, and I'm working with World Resources Institute India. So this is actually my second time presenting in Urban Arc. Thanks to IIHS for giving us this wonderful platform. So today I'll be presenting on planning for urban infrastructure of care in vulnerable neighborhoods of the Global South. Before going into the details of the research, let us understand what does care work entails. So care is the heart of social reproduction, which helps to maintain the existing life and also to reproduce the next generation. However, historically, the work of social reproduction has predominantly performed by women and persistently undervalued and under-recognized. In the present, we are facing modern crisis of care, which is burdening the caregivers, straining their capacity to care, also impacting the marginalized caregivers who lacks accessible caregiving resources in vulnerable settlements. So, through the urban infrastructure of care, we are actually trying to understand caregivers' day-to-day efforts to meet the needs of their dependents, which is heavily relied upon the availability and adequacy of specific components of the urban environment. Through this, we will try to equitably redistribute resources for and burdens of care in cities. In the interest of the research, we will be looking into the urban infrastructure of care through the lens of caregivers and children. So globally, there are around 500 million children who reside in vulnerable settlements and faces disrupted caregiving due to poverty, absence of basic caregiving facilities, and climate disasters. But it is important to understand why care is important for their development and overall growth, as disrupted caregiving can lead to risk in brain development, mental health concerns, and weak stress coping mechanism in adulthood, binding them into a cycle of intergenerational socioeconomic hardships. So prioritizing care, planning in vulnerable neighborhoods will help us to break this cycle of adversity and promote health and socioeconomic equity. So this paper aims to integrate the perspectives of caregivers and children into planning for care in vulnerable neighborhoods with a specific focus on factors empowering caregivers and their children so that they can actively manage their own well-being. Coming to India, 1 in 8 children in India resides in slum, facing alarming under 5 mortality rates and newborn underweight statistics below the developing nations. Like many other slum redevelopment policies in India, Jaga Mission, an initiative by Odisha government, primarily prioritizes securing basic amenities, neglecting the unique needs of the caregivers. Along with the Jaga Mission, Odisha government is also involving women's self-help groups, which are actually primarily consisting of the caregivers from the vulnerable settlements in constructing and maintaining basic facilities in cities. However, this well-intentioned approach is inadvertently amplifies their caregiving burdens without addressing their essential caregiving needs and thus hindering the socio-economic opportunities that the government is trying to provide. So, throughout the 3 years under the Nurturing Neighborhood Challenge, we have been working with Rourkela, a city in Orissa, towards making the city a child-friendly city. Throughout this challenge, we have been involving caregivers, not only maintaining the places, but also planning and implementation of child-friendly projects. We have also facilitated women-led data mapping for identifying the care-centering projects that is needed by the caregivers, and converge various slum-centric policies on ground and clustering caregiving facilities. All these methods played an instrumental role in creating care spaces in slums defined by the caregivers. One such example is combating decade-old stigmatization of leper caregivers. So in one leper colonies in Rourkela, we conducted a transact work with the caregiver ecosystem. So the ecosystem consists of the primary and also the secondary caregivers, which are the parents, grandparents, even the Anganwadi teachers. To understand the care burden, we understood that caregivers were sensitive about letting their children play in the unhealthy surroundings within the slums, as they fear it will cause them infections which will look much like leprosy infection. And so they did not let their children to play outside, and they could not take them to the other colony parks due to the persisting stigmatization. As we can see in the words of one Anganwadi teacher, as she was not belonging to the colony but was serving the colony as an Anganwadi teacher, she also faced the stigmatization. So my friends advised me to take bath thrice after coming back. So mapping the nearby play spaces visited by the caregivers, it showed us the unequal distribution of play spaces in slums versus the rest of the affluent colonies. So with the help of the community, we created a formal play space, which encourages the children from neighboring communities to come to the slum, breaking their social stigma. This public space became a thriving space for the nearby caregiver communities for conducting women SAG meetings, health camps, developing an inclusive public realm for everyone in the community. So understanding the impact of the small intervention, the local government converged various state schemes to develop open gym, paved pathways, and many other facilities which actually empowered the caregivers within the community. As in the words of Gopal Bini, we are happy to see that outside communities are coming to our slum now, which makes us feel dignified. We feel we have become same now. There is no difference between us and them. So other than the project-centric intervention, we have also initiated a capacity building program for caregivers and Anganwadis teachers from slums, integrating their needs into the planning solutions. So utilizing the GIS-based spatial analysis, we strategically assist caregiving infrastructure, bridging the demand and supply gaps in Anganwadi centers. The approach empowered women caregivers in active care planning, granting the control over critical metadata towards the planning for care in cities. This resulted into a scale-up plan of creating 120 new Anganwadis in the slums of the city, shaping the city-level urban infrastructure of care planning. So throughout all these approaches in Rourkela, it helped us to evaluate the existing slum redevelopment policies through the care lens, aiming to create a replicable model in India and in other global south countries that recognizes the significance of caregiving in vulnerable settlements. So towards the way forward of planning for care entails identifying barriers towards fulfilling caregiving objectives in vulnerable settlements, using participatory action research and community-based participatory research tools, and also conducting pilot surveys and household travel diaries within the caregivers' constrained 300-meter diameter walking range, which help us to plan the urban infrastructure of care system in vulnerable neighborhoods. Guiding formative research can also help us to identify barriers related to the health equity for children and caregivers in vulnerable neighborhoods. All this will inform the care planning system, shaping slum redevelopment policies in these vulnerable settlements. Care planning can also help us to respond to the climate resilience approach, as caregivers and children in the vulnerable settlements face severe climate change impacts, rendering them more susceptible to the health-related issues. As an example, even relatively low levels of air pollution exposure during pregnancy can lead to the birth of smaller babies. So integrated climate resilience into the daily community practices by caregivers demonstrated the potential to transform their vulnerability into opportunity. So in the slums of Rourkela, as an example, we involved the women SAG workers in creating the rainwater harvesting systems, air purifying plants. So this practice of it actually helped to combating the climate disasters and help us to give the significant contribution to climate action plans. So through the research, we are trying to see that how can we increase the access to care, which is crucial for the challenges faced by the vulnerable women caregivers in an urban setting. This will also help us to support the future generation and opportunity to equal growth and healthy development. Prioritizing young children's and caregivers' health, well-being, inclusion, and integration into the broader city systems, the paper aims to formulate theories to guide local policymakers in using spatial analysis to prioritize care planning and policies in vulnerable areas. This will empower the caregivers and young children communities to lead a global movement for urban care. Thank you.
Looks like this panel is going to end before time. Okay, I'm actually going to open it for questions from the audience and then perhaps add my questions as we move along. Yeah.
Thank you. So I'll start with the question to Arunima. So one methodological question about the intervention that you're talking about. So what was the extent of involvement of men in care planning? So in the pictures, I didn't see men in the discussions. And secondly, I would like you to comment on, there's a discourse in planning about, see, we generally talk about women's double burden, like domestic work, employment. So there's a discourse about third burden also, which is contributing to the community. So we know Anganwadi workers are already not considered workers, and such interventions give them greater responsibility to respond to these interventions. So how would you comment on putting additional responsibilities to community workers?
Yeah. Okay.
Two options. Hi, my question is to Arunima. I was very interested. So there's definitely an infrastructural approach to care, right? What you primarily focused on. I'm more curious about the non-infrastructural approach towards care when it comes to, let's say, policy recommendations. You talked about Jaga Mission, right? So what kind of negotiations you had to do with the state officials to kind of make any sub-clause changes in a particular sort of a regulatory framework, basically, which kind of makes it more scalable and not just based in one or some communities in a city in Odisha?
So I have a question for Prerna. I was wondering how your ethnography speaks to a very large volume of work we have on actually women fetching water kind of an exercise, right? And the context there is often rural, and the metric there, the burden is seen on time and effort. I found it interesting that here one of the metric was pain, right? Bodily pain as a cost for procuring water. But on that, as well as one is the impact on women's hygiene, but the other side of it, which is, I'm a bit surprised that with the finding that women were in favor of toilets, not to say that they're not, and by toilets you mean toilet in the house. So how does that, I mean, I don't know if you explored, speak to like a Swachh Bharat sort of messaging? And did they not anticipate the burden of actually keeping it up? Yeah, that would be interesting.
My questions to Prerna as well. Thank you for the presentation. It was lovely. I was hoping you could think out loud a little bit more on the water as infrastructure point, and then where would you think the most immediate interventions or propositions are necessary? Like, if they're talking about like, if their current system of getting water is through tanks and all of that, but necessarily bringing them into the grid system might not help anybody. So if they are getting water till their place in tankers, then is the intervention we need to build in creating better support systems of how they get their water into their houses or into their safe spaces? Or do you think it needs to start at like a reimagination of like menstrual health schemes, where most of the schemes now focus on getting them resources of menstrual sanitation products, but then water and space is fully not in that imagination. And even if you build toilets, the much bigger problem is operation and maintenance of it. So how do you think like that can be supported, or like where do you think is the like first priority intervention?
Hi. My question's to Arunima. So in the project that you were talking about, care is specifically concerned with this particular community of slum dwellers in Rourkela, right? And their experience of the barriers to being able to provide quality care for the children are located within that context, that ecological, social context. So mostly concerned with things like the children not being able to play because of social stigma and not having the actual space for it and things like that. So my question is, to what extent do you think those concerns are universal across similar locations in India? And also, in what sense, I'd like to ask you to talk a little bit more about what you mean by care infrastructure in a broader sense related to broader and more different contexts. Thank you.
So my question is for Mohit, Anuj, and Khushbu. So I just wondered, how did you study the active functionality of MCP card, especially in Gujarat? Like the MCP card is very exclusive while we are talking about the health in between mother and child. I know 14, it's an exclusive state. So how did you study about the MCP card?
Okay, I'm just going to throw one question in the mix for Maryam. You know, you use the phrase dystopia and healthy urbanization, and meaning to suggest that it's the utopia that's failing. I'm just really curious, what's the starting point of that kind of a framework for studying urban health, and if you can reflect on that a little bit more.
Actually, it's a funny story. I was watching one of my favorite series, and there was this arc which was talking about a very flourishing nation, but behind the flourishing screens and illusions were something very deprecated and shallowness and sadness and all kind of illness the world has to contain. So this occurred to me. I really wanted to work on urbanization and on health because my academic background is more of health. So I was curious to know how health and these infrastructures, urbanization, city works together. I am from Islamabad myself, and I've never seen these kind of slums or kachi abadis that exist in there. I never knew that people are living in these kind of conditions. And on my first free work, I was shocked to know that something like that exists. So this idea came to me that I need to work on it. It was a shocker. Seriously, that people like that poverty exists in the world, but then that exists in Islamabad. So that's why I come with an idea that Islamabad is listed as one of the most beautiful capitals in the world, and then there exists something like that in small alleyways and dark, deprecated and humid concrete exists in those dreamlike spaces. So that's why I know that Islamabad was a utopia, but the hawks soon break when I started working on the idea of dystopia and that.
Okay, thank you for that. Arunima?
First of all, thank you for the excellent questions. So I'll start with my first question. So men in care planning, I think that is a lacuna that we have been facing in our work and also in research. So I would like to say from one of the example of one of the slum that we are working. So there was a place which was very negatively impacted. So there were some negative activities which to happen by men over there, which was used to be a play space, now broken down and used by those men for negative activities. So even though there was a temple space beside, the women were scared to use a space and even go to the temple in the evening. So what happened when we collaborated with the SDS, Slum Dwellers Association within the slum, so we understood their problem, which they are facing regularly because they have to go to the temple, but they are not able to. And that helped us to come together with the community and put forward this approach that what if we change that area itself into a budding space for the community so that everyone comes to that place. So we created, like there was an example of clustering that is actually from that place where we kind of implemented one Anganwadi, mobile library, open gym, and also a play space looking into the need of the various stakeholders which are connected to the caregiving ecosystem directly or indirectly. This helped us, so we perceived that this will change the whole impact, and then we will expect to see a lot of children in that area. But in exchange, what happened that more women are actually found in that area who used to come to that place for various kind of activities. They were very happy to use the gym. They were very happy to come to the macro activity center where they can spend time and then use their time for some socio-economic activities. So, so this helped us to understand that how to anchor those public spaces in slums with the help of the community and revitalize it. So as an output, what happened when the men saw that there were so many people who are coming to this place, they started recognizing the place as a care space. So they also started coming to the place with their children to spend time over there. So that was a major change that we were able to see. So, but definitely there is a lacuna that that is had to be told. And then the next question is about okay, yeah, so about the shift. So, like, I think your question is also connected to the second shift that we are facing right now, which is actually pushing the women to the workforce. Recently, there are many other policies that are also coming, which is trying to see how women caregivers, not only women caregivers, but women for vulnerable settlements can be involved into the socio-economic opportunities, which is also a capitalistic measure. So what is happening through this is, like we discussed, that when we are pushing them towards this economic cycle and not taking care of the caregiving needs, it's actually burdening them more. So they are not able to achieve the socio-economic opportunities and also being bound by the whole process. So that is why we need to, if we can provide these caregiving system around them, which kind of, and also value, add value to the caregiving infrastructure or the care work itself, then actually we can create a change where it won't become a burden for them, but maybe an empowerment for them, where they can also take decisions and being empowered to plan for their own communities however they need it. Okay, coming to the third question, I think infrastructure of care and the policy recommendations that we are doing in with the Rourkela, we try to infiltrate our understanding so that it can be replicated in state policies. However, this has been a very limited measures that we are able to achieve, but there are certain impacts that we can see. So before, I think even in the last year, Jaga Mission was mainly talking about the basic infrastructure, but even only in this year, they have added as a 9th vertical, which talks about the creating play spaces in slums. However, it's a very minuscule change, but this is where we are starting to create that change of understanding caregiving responsibilities or care spaces in the redevelopment of slums. Okay, coming to my fourth questions about the care infrastructure as an universal approach. So here we are talking about here in the presentation I talked about a very specific approach in Indian scenario. But if we see the broader research that is happening globally on care infrastructure, we can actually see it compiles a lot of domain which talks about the public, private, economic sectors, material needs. It may be a grocery, maybe a caregiving needs, or even it depends on the receiving of the caregiving for the caregivers also. Like we say to bring like we say ki we need a proverbial village to help a child to grow, but in our economical system where we are becoming more to maybe very small family system, so getting help to take care of a child is becoming really difficult, and this is what is pertaining the care crisis. So coming to the care infrastructure in Indian scenario, it doesn't only take care of the play spaces per se, but also takes care of any needs. So there are two different ways of seeing it, that we should not universalize it because it can change and depending upon the context and the spaces we are doing. And within that, we can also find the major infrastructure which is already in place and try to involve the caregiving or better the caregiving through that, like primary health centers, or maybe play spaces, and then Anganwadis also, and also the community centers, which can also become that caregiving spaces while the mothers are actually taking care of their economic opportunities. So there is a number of ways we can experiment on that, and maybe find out more ways to put caregiving value to many infrastructure that are already existing. Thank you, everyone.
If I can just quickly, add to that, actually, the question that Shraddha was also asking perhaps was about, as we build more care infrastructure, are we already burdening women who provide care? If I hear correctly, right? Like, so for example, the Anganwadi workers are already stressed because, they're looking after the Anganwadi system, and every few years something new is added to their, plate. And now with care infrastructure becoming separate from the MNCH outcomes of the Anganwadi, are we really overburdening the caregivers in some sense while we imagine, bigger, newer care infrastructure in the way we are conceptualizing it?
Yeah, thank you for explaining that. So I think, caregiving infrastructure is not necessarily, like I was telling in the last question, is not essentially understanding or redefining a new structure. It is actually trying to infiltrate within the existing infrastructure and trying to value add to that, so that, like, if you're saying there is already an Anganwadi, there is already an Anganwadi worker, but whether their needs are being heard or not. Like when we are working with this Anganwadi in Basanti colony, so we kind of met with a very passionate woman who talked about that, for me, my home is this Anganwadi. I spend the most of my time here, and the children also doesn't live, would like to stay here for a longer period of time, but we don't have anything to provide to them. So what we provided is that outside of the Anganwadi, we provided a play space, kitchen garden, and many activities which will help them to do a better learning through that. So what we are saying is that we are not trying to redefine the existing infrastructure or trying to put another term on top of them and say, okay, this is something new and then you have to follow it. But we are trying to enhance the existing infrastructure which has been undervalued consistently throughout the years, and trying to see that how that can change. So one major understanding from this approach happen is that how do we see the outside areas of those facilities like PHCs, Anganwadis, even public, any government buildings like municipality government building, and try to see them through caregiving lens. So if there are n number of women who are coming to a municipality every day for their grievances, whether do we provide a seating space, a breastfeeding pod, or maybe a care creche within that institution for the mothers to take care of their child. This is how we are responding it to them.
Okay, thank you. Prerna?
Thank you so much for the question. To answer the first question about toilets, and toilets are a very interesting conversation in the field because there are varying views about toilets, but where toilets become important is that there are 6 community toilets in Kusumpur Pahari, out of which only 2 are concrete structures, and they're the ones that are most used. But due to lack of space and how, like the geography of the area, both of those the CTCs are located on the outskirts. So there's this added concern and conversations around safety to going to these places to use the toilets, specifically in winters because it's shorter days, it's colder, there are less people on the street during evenings in Delhi winters. So there's this added idea of how to use these CTCs, how safe they are. Another thing is that they close at 10 p.m. Yeah. So how do you access these resources in night? It's not like you only have to use toilets between 8 a.m. and 10 p.m. So thus it becomes important to have easy accessible toilets. But yes, to adding to your point, women do anticipate that it's going to add to their burden of both negotiating the water access, like how water is going to be used and for how much for what. And also the burden of cleaning and maintaining those toilets also are based on, is on them. But another aspect which comes into play when we talk about toilets is this idea of community and kinship, because there are a lot of extended families also living there for a very extended period of time. So they do use the toilets of extended kins, of neighbors in cases when they can't use yours. So there is this collaborative effort also to try to access these resources. Another thing about toilets are that they are made outside of the houses. So that is again an issue of, during one of a very informal group discussion with 4 women, one of whom said that I have to go outside every time I have to use the toilet because it's just outside the main gate. And she finds that very uncomfortable because everyone knows when she has to go to the toilet, and that is a very big concern around privacy also. So there is no one easy answer to try to understand how toilets are accessed, especially during menstruation, because it depends on both the geography. Those who are living near the CTCs do access them a lot. Again, due to the water problem, CTCs also are very hard to maintain high hygiene and cleanliness and all those things. So it's a very dynamic and changing idea about how toilets are to be used, and how privacy is a huge concern when it comes to accessing these resources. Coming to the second question about water as infrastructure, that's a great question. I wish I had a straightforward answer to that. Definitely, the first thing that people talk about is water and how there is a need for piped water, which they don't have. So that's definitely the first concern people have. A lot of old women that I talk to have been living there for 50 odd years. They say that nothing has changed. Earlier we used to go till Arkepuram to get water. Now one good part is that the tanker comes to the community. Another aspect of it is where your house is located within the community. So the tanker, it's a very narrow main road in the A block. So where the tanker comes, all the houses that are there, it's easier for them to transport water. But then there are narrower lanes as you go inside, and it's much more difficult for them to carry that water. So obviously it depends on your class, location, what kind of labor you have to carry that water. A lot of women come there with their daughters who guard the cans by the time they transport 2 cans at a time on cycles. So obviously piped water is one thing that is the primary concern and the primary aim for it. And a very interesting thing here is that there are pipes. They were constructed around 7, 8 years ago, but there's no water in them. And because of the DDA scheme of trying to redevelop these informal settlements, Kusumpur Pahari comes under that scheme. A survey has been done about how many family members are there, but there hasn't been any progress on that. So that piped water infrastructure just stopped there. So yeah, I hope that answers your question.
Thank you. Anuj?
Yeah, so thank you for that question. Yes.
Sir, will it be fine if I take this and perhaps you can add?
Yes,
Sure,
please do.
because I just wanted to share something when this question was asked.
Sure. Go ahead.
Yeah. So mother and child protection card focuses on tracking the child since its conception till first 3 years of life. So simple answer to this question was our study focused mostly on adolescents. So basically, we didn't actively track MCP because it was not our study's core objective. But I would like to share just one thing, and this is not related to this question because we didn't track this. For example, when we attended the Mamta days, just as an observational activity, we realized that the tracking mechanism can be a little bit more overburdening for the community-based workers, ASHAs and ANMs. Reason is because at that time, Techo Plus was being rolled out based on Seva Rural's IM Techo model. And actually, Techo Plus was rolled out to make the work of Ashas and ANMs easy. I mean, directly entering all the tracking details about immunization, ANC, and all into the app. But actually, what was happening was, since any technology comes with its own downfalls, the ANMs were actually recording all the details first on a register, and then they were transferring it into the IM Techo app later. So there was some data loss, and they were not so much happy with this entire operationalization. Over to you, sir. Thank you. Yeah.
Yes, thank you, Mohit. So I'll just add a couple of points on what he said. So it was not the area of our study because it was related to adolescent, but they were going to give peer educators diaries to adolescents. Then there are these Mamta cards, what Mohit was mentioning under RCH programs. Then there are these Niramay cards under Health and Wellness Center program, which are being rolled out right now. Then there are OPD case papers. So what happens with these different types of cards, which are supposed to be maintained by community members, that is the expectation. So there are three types of issues which we found not from this study, from other studies. First are communication issues, because many times, as Divya was mentioning, the community health workers are also other caregivers who are overburdened. कोई भी program आए, then it is up to Ashas and Anganwadi workers, it is allocated. So there are many gaps in the way communication happens. For example, in one of our field studies, what we had observed, the two extremes. One mother was really कि मेरे बच्चे ने तो फाड़ दिया, तो card was torn out by the child. And there was other mother who had laminated the card because she found it is something very so special. So the health workers couldn't write on it because it was laminated. So these kind of extreme issues in communication which we observed. Then there are access and reach issues, because the timings in which Asha worker goes to community and timings in which people have their lifestyle, they really don't match. So many houses are closed. Then there are in one of the areas also substance misuse issues. So Asha worker really find unsafe to go into that area because people are drinking and having liquor. So she just skips those kind of houses. So these reach issues were there. And again, there were linkages issues, especially in Surat with migrant population, because people take the card, then for delivery or after delivery, they go to their native state. And then there are linkages issues which happen in the source city and destination city. And as far as the way of studying this functionality, we used the participatory observation approach in ethnographic lens. So we actually tried to be with Asha workers in their field work on the Mamta days, and we also tried to help them with their, register filling up and other things. So we tried to capture as much insider's perspective as we could during this study and other studies. Yeah, thank you.
Okay, thank you everybody for your time.